Today we'll be discussing about approach to diplopia. So we see a lot of patients, especially in our inpatient wards, patient presenting with some CV or something where they on examination you will find cases with ophthalmoplegia or like oculomotor palsy or like absent palsy, like some movement restriction will be there. They'll have some upward gaze restriction or downward gaze restriction or lateral gaze restriction will be there. So today we will be discussing about how to approach a case of diplopia. So they generally present with the complaint of diplopia on examination, or sometimes most patient may not complain diplopia, but on examination you will find some kind of ophthalmoplegia is there. So before going into diplopia, you need to understand what are the symptomatology you need to ask for diplopia, whether it is a monocular or binocular diplopia. Monocular diplopia is that when you see it one eye, on one eye exam, like when you close the other eye, only one eye you are seeing, you are having diplopia. That is monocular diplopia. Binocular diplopia is when the two eyes are seeing together, then they have diplopia, is binocular diplopia. Coming into the monocular diplopia, most of the cases of monocular diplopia are ophthalmological, some corneal or cataract or some other like local eye is the cause for monocular diplopia. Very rarely underlying neurological condition will be there in the case of monocular diplopia, or some orbital issue might be the cause in the case of monocular diplopia. So how do you tell the monocular diplopia is purely ocular, or whether it is some neurological condition is involved in the case of monocular diplopia? To tell that, do a pinhole eye examination, like do a pinhole examination, ask them if they're still getting diplopia after still looking at pinhole or not. So through the pinhole vision, you can be like, if you go for refractory testing or something, they'll put a pinhole before your lens and check if you're having vision is improved or not. If by after putting the pinhole, if your vision improved and if it is good, no diplopia is there, that means there is no underlying neurological condition. Mostly it is mostly due to refractory or some squint or something, some corneal issue or some lens issue or some local orbital issue. So most of the cases of monocular diplopia are mostly like when only one eye you are having diplopia, that is mostly local ocular problems. On pinhole examination, if it is normal, then neurological causes might be ruled out. So coming into the binocular diplopia can be due to vast number of causes. So that can go from the supranuclear, that is around brain, cortical level, to the brainstem level, to the nerve level, to the neuromuscular junction level, to the orbital level. So it can be due to many causes. We'll discuss in the further slide what are the possibilities of binocular diplopia, how can it occur. So and that is all we will be discussing in the next case based scenarios. Coming into the previous history, always ask if there is a previous history of diplopia or any trauma is there, any history of trauma, because one of the most common cause, we find a lot of cases with superior oblique palsy, where the abducent nerve is abducent nerve is in superior oblique palsy, where the abducent nerve, fourth nerve, is damaged. So most common cause of fourth nerve palsy is always trauma. So previous history of trauma always needs to be asked, because this trauma can cause damage to the whatever trochlear nerve or abducent nerve or whatever. Most common is trochlear nerve, but they might not manifest immediately, because with the age, because of the age and degenerative changes, they might manifest in the later stage after 50 years or something. So they might manifest it better. So the history of trauma always needs to be asked, because they can cause isolated nerve paralysis and all. So they all needs to be asked. And coming into the comorbidities, always ask if there is any underlying diabetes, hypertension, dyslipidemia, any history of CVA, CAD, anything is there. Because one of the most common, when you come to a case with diplopia, you always jump to the central causes. Like you always look at cerebellum for nystagmus, you look for the brainstem lesions, you look for the cerebral cortex and all. But only 10% of cases have a central cause. Like they have 10 to 15% will have the central CV or ischemic bleed or TI or whatever it is. But most of them will have local isolated cranial nerve palsies, or some of the local eye ocular problems or orbital problems will be there. So one of the most common cause of diplopia, 50% of diplopia will have isolated cranial nerve palsies. So that can be oculomotor, that can be abducent, or something that can be trochlear nerve. Common cause of oculomotor nerve palsy is generally ischemia. So secondary to some diabetes or hypertension or dyslipidemia, they'll have vasa nervosum will be there, no, because of that ischemia will be there. So that they'll have pupillary sparing oculomotor palsies. So they will be they might be transient, they might be reversible if you manage the diabetes and dyslipidemia well. So always ask for comorbidities, because ischemia related isolated cranial neuropathies are also common. So diabetes, hypertension, dyslipidemia, especially third now. Like sixth now I told, fifth, fourth now I told it's mostly related to trauma. Third now is mostly related to ischemia and all, that localized nerve related ischemia. And whereas sixth now is mostly due to the raised ICT or tumor or mass or something. Always ask for that. Then ask for any history of strabismus, like any squint is there, like whether it's present continuously or latent squint is there, because squint also can cause diplopia. Because of the long standing squint, the eyes are malaligned, they develop diplopia in the later term. So they might not tell diplopia in the initial stages of their childhood, but the later on with the age going on, they develop diplopia in the later on, they might manifest it present at the later age in life. So always ask if there is any squint or not. So always ask with a constant or intermittent, like if it is constantly present or intermittent, like when you tell, how do you call it, if the diplopia is persistently present or it is coming in between and going. Like let's say sometimes diplopia will be intermittent, like when you have to focus on a certain object, when you're doing something, or when you're having stress, like you're working on a computer, you're looking at the computer for a long time, then they develop squint. So that is intermittent squint. Sometimes it might be common, like sometimes after latent squint people, like intermittent diplopia. So intermittent diplopia sometimes might be common in such people where after long standing sitting at a computer desk for looking at the computer for a long time, they develop, because of the contents eye strain, they might develop diplopia. That is intermittent diplopia. Or sometimes because of the latent squint also, they develop intermittent diplopia whenever the latent squint is coming on. That might be benign, sometimes not something worrisome. Whereas constant diplopia, despite of whatever you are doing, wherever you are looking at, you develop diplopia. Constant diplopia is something that should raise a concern. Always worked up for any oculomotor and both neurological problems. So intermittent diplopia can be sometimes be common after long strenuous eye work, or something latent squint can be a possibility. So these all needs to be looked at. Then one more thing is physiological diplopia. So what is physiological diplopia is when you're looking at a hand, you're looking at a hand per se. So when you're looking closely at a hand, all the objects behind the hand, like the behind hand, let's say behind the hand there is some kind of tree or something. So the tree might look blurred or diplopic. Certain double vision might be there behind the tree, because you're focused on the hand. That is physiological, because your eye complete focus in the hand is your eye complete focus is on hand. So whatever behind it sometimes might look blurry or diplopic. That is physiological. So when your focus is on a certain object, whatever is behind, like that is portrait imaging, like bokeh picture, like when you are focusing on a subject, all other behind might look blurry and diplopic. So that is the same thing happens with an eye. So they are called physiological diplopia. When you are looking normally, then that diplopia might not be there. So that is also important. Next, gaze specific. So what gaze you are looking at, like if you are having horizontal diplopia or vertical diplopia or torsional diplopia, these are all important. Like horizontal diplopia, when you're looking to the right, if you are having like diplopia on the right vision, is there, like when you're looking at the right, you are having diplopia, then you might suspect there is a diplopia something related to the right abductor palsy, like right sixth nerve palsy might be there, or left third nerve palsy might be there. That you know, like horizontal diplopia are mostly due to the medial recti muscle, the medial rectus and lateral rectus might be involved. Whereas vertical diplopia were up and down mostly due to superior and inferior rectus. And also like any torsional, like when you're reading book or looking down the stairs, when you look in torsion may be required, like superior obliques needs to be involved. So they can be due to the torsional diplopia. We'll discuss about torsional diplopia, vertical diplopia again in the later part when you're having case discussion on. So that is also important. So these are all important when you're discussing about the case, how what kind of diplopia. This will help you to guide in what kind of diagnosis and what is a possibility, because monocular is mostly ocular, binocular is mostly neurological. Any previous history of trauma will tell you there is neurological. Comorbidities will tell you about ischemia, strabismus, constant and intervention, gaze, if there is any specific gaze, that is important. And orientation will tell you whether horizontal or vertical or torsional. So we'll discuss about diplopia, horizontal and all again. So this is the history you need to ask. So with this history we'll go into the first case scenario. So a 64-year-old man presented with the evaluation of double vision, so that he had experience since last 1 month. So he initially noted the double vision while reading his morning newspaper, but over time he became aware of similar visual disturbances when he is attempting to descend stairs in the local shopping center. So a detailed history revealed that he did not have noticed diplopia with other activities. So classically, when they're having diplopia, when they're reading newspapers or when they're walking downstairs, so what will require when we are looking at the news, when you're reading newspaper, one thing you require is convergence. So medial recti inward. One thing is intorsion. Intorsion of muscles needs to be, because we have to look down and all. So superior obliques are involved. So superior obliques classically will have complaint of reading newspaper or walking down the stairs, they'll have classically this symptomatology, like when they have diplopia when they're walking down the stairs or reading newspaper. So that is one more thing. The double image was obliquely oriented and binocular. So this is oblique orientation. So what I told you, that oblique and torsional orientation is classically seen with superior oblique muscle, like obliques are most commonly known. So he stated, when I close one eye, then the other I want to read, then it goes away. So it is binocular. When he closes on one eye, he is able to read with other way normally only. So the patient did not have eye pain, ptosis, dysphagia, dyspnea, or other neurological symptoms. During the patient interview, the patient related that he had been having involved in the motor vehicle accident in the 30s, and which he has been knocked for out for a few minutes. So he has history of motor vehicle accident 30 in 30 years, like in 30 years ago, where he was unconscious for few minutes. So the oculomotor examination revealed a left hypertropia. So the left hypertropia is there. There is no third no palsy. They didn't mention anything about the medial rectus palsy. Convergence is all normal. So there is no problem in that. But pronounced in there is left hypertropia when it is mispronounced on the right gaze. The patient has endorsed diplopia when looking down and asked like conjunction. He sees two lines which are straight and one is diagonal, which is extended to the left eye. So generally what will happen in the superior oblique muscle is they'll have problem in intorsion and depression, and abduction is the main thing of the superior oblique. So main thing is the intorsion. So intorsion will be a problem. They have hypertropia. Diplopia is problem as mentioned. So what they compensate to do it, they tilt the head to the opposite side. So when there is a left superior oblique palsy, so left hypertropia is that they tilt to the opposite side so that they can have oblique vision will be there. So to compensate that, they'll tilt the head to the opposite side and look at it. So this is called cascalic symptom of superior oblique palsy. So the patient had head tilt to right, which is on requesting of the family photographs. Family photographs also showed he had tilt to left side, like right side. So this is a classical case of superior oblique. As he mentioned, 64-year-old male presented with difficulty in diplopia when he's looking at the newspaper or walking downstairs. He has left hypertropia and head tilt to the right side, and he has oblique diplopia, more like he's tilting to compensate for that oblique diplopia to the head tilt to the right side. So this is a classical history of superior oblique palsy, mostly abducent nerve palsy, maybe left abducent nerve palsy. Since there is a history of trauma, maybe a trauma related to abducent nerve palsy, which is manifesting now because of the degeneration, because of the age related degeneration will be over, it will manifest in the later side. So this might be a case of trauma related to oblique nerve, like abducent nerve palsy. So always ask for the history of head trauma. So this is a classical case of superior oblique. So any superior abducent, first intorsion will be affected, then depression and abduction. Same with inferior oblique, it will be extorsion, elevation and abduction. So that is inferior oblique muscle. So this is one more thing. Superior oblique, it will affect intorsion. They'll have symptomatology of looking downstairs and all. So they have head tilt to the opposite side, and they also left whatever side of eye is, that is hypertropia is there. So that is the classical symptomatology. Here the trauma is the cause. So description is associated with oculomotor left fourth nerve palsy with age-related decompensation. So this is the standing head tilt is there. So head tilt is there, always suspect obliques. If there is a head tilt, always suspect obliques. So coming into the diplopia, horizontal diplopia. Horizontal diplopia is when you're looking at the sideways, like mostly medial rectus or lateral rectus will be involved. So that is the classical. Vertical diplopia is when you're looking up and down. Let's say when you're looking up and down, you have some difficulty. So when you're looking, like when you have a billboard of images. So when you're looking below image and upper image, that diplopia is there. That is called vertical diplopia. And vertical and torsional diplopia is what classically seen in the case of superior oblique and inferior oblique. How they present is, so they have some horizontal, like oblique diplopia. So when you're, and there are four images are there. So in the case of superior oblique, in the right corner image, they'll have some diplopia, so that they'll compensate by head tilt. So there are four images, like the right corner image, when there is looking at the corner image or something, they'll have head tilt, so they have oblique diplopia, and they'll have a head tilt so that they can compensate for that intorsion, so they can bring the eye up and watch it. So that is called vertical and torsional diplopia. They will classically have head tilt and intorsion difficulties, and like I told you, they're more have convergent difficulties in the case of superior oblique muscles. In the case of inferior oblique, opposite, they look at the sky or flights, they'll have difficulties. So that is oblique and diagonal. And like then the oblique or diagonal is something where both horizontal and vertical are involved. Like I mentioned, in the case of oculomotor palsies, they'll have involvement of both horizontal, like both recti will be involved, medial rectus will be involved, inferior oblique will be involved. Both mixed is the both oblique or diagonal is what is called. So there is one more thing called comitant diplopia and incompetent diplopia. So what is comitant diplopia is this does not change with the gaze. So incompetent diplopia is what changes with the gaze. What is comitant diplopia? There is no gaze. There is no gaze related change. So mostly it is related to congenital strabismus or something. So whereas incompetent diplopia, which changes with the gaze, is the main problem for us. So if the diplopia is changing with the gaze, let's say it is worsening with right gaze or left gaze or upward gaze or downward gaze, that should raise the main concern in our head, in our head, that it is some neurological problem or oculomotor problem is there. But if it is not changing with the gaze, that means if there is some kind of squint is there, so or some skew deviation, some kind of strabismus is there. So if incompetent diplopia, when there is changing with the gaze, then it should raise suspicion some extraocular muscle dysfunction or some underlying condition is there. So this is the cause of diplopias. So how do you examine diplopia? So there are various examinations you need to do in the case of diplopia. First thing, you ask to fixate at one point and look at him. So then, and when you're asking to fixate at your nose or something, always look if there is any nystagmus or not. And also I check for any gaze evoked nystagmus, and if there is any like on fixation also, if there is nystagmus also, spontaneous nystagmus also, it should be like okay. Then also if there is asked for any square wave jerks, like any involuntary jerks are there or not, you check for. So if he is able to fixate or not, if there is nystagmus or like intermittently jerks will be there, that is called square wave jerks. So any square wave jerks or nystagmus, always look for if there is any central cerebellar problem or brainstem problem is there. So first examination that needs to be done in any case of diplopia is first fixation. Fixate the eye at a certain nose, your nose or some fixating point. Look for any certain involuntary jerky movements or nystagmus is present. So if it is there, look for any brainstem problem or cerebellar problem. Sometimes nystagmus can also be due to the auditory problem, as already mentioned in the case of vertigo dizziness. Once watch it again. So then monocular eye movements. So then ask for any first check the each eye for lateral rectus, medial rectus, superior rectus, inferior rectus, superior oblique, inferior oblique, and all. So then like all the movements, like the opposite eye also, you need you need to do the same. Then you look for any limitations are there, any restrictions are there, you need to look for. So then also look for any visual field like normals, if they are able to track the movements and all. That is in single eye movements. So then binocular. After check the each eye separately, then you look for binocular. So first thing is there version movements. What is version movements? So let's say you move the hand to the left. So both lateral rectus and medial rectus are coordinating or not. So then you move to the right. If the right medial rectus and left lateral rectus are moving or not. So and then you move eye upwards. So both eyes are going up or not, like downwards, like. So this if their conjugate movements are there or not, you should check. So then this plays and then you need to look at pursuits also. Like pursuits, it's like smooth following around. You move the hand aside and you look whether the eyes are following or not. So pursuits are also affected in the case of brainstem and cerebellar lesion. Then you look for saccades. Saccades is how you check for saccades. It's put your two hands on the opposite side, like to extreme ends, to the two extreme ends of the eye vision, eye field of vision you put, and you ask them to suddenly shift his vision from the one hand to the one finger to the other hand finger. Like one hand is to the left, extreme left, and one finger is to the extreme right, and you have a nose in between. So you ask sudden shift of vision, like once you ask him to look at left, then right, then nose, then left, then right, left nose. So this will tell about the saccades. This saccade is the fast component. Like I'll give you what is saccade. So you're sitting in a train. So there are lot of poles, and when your train is moving, there are a lot of poles and trees passing by you. So that sudden shift, like you are able to watch all of them, because sudden shift of vision will be there from that. Saccadic movements will help you to track every movement. This sudden shift in movement, this sudden jerky movements will which help you in keeping track of all these objects moving past you is called saccade. So the same way we are testing here with sudden shift of movements from left to right and nose and all. So this will help you in telling about the this should be done both horizontally and vertically, upward and up and down also. This will tabulate saccadic movements. So these saccade and pursuits are mainly a function of brainstem and cerebellum. So always if the saccades and pursuits are there, if some conjugate movement defects is there, always look at the brainstem and cerebellum problems. Mainly brainstem is the problem. So this is helpful in diagnosing. So first we discuss about fixation, where the nystagmus and square wave jerks, which is also a brainstem and cerebellum problem. Then monocular movements. So monocular movements, if this is only single palsy or something, then you look for isolated palsy. If you are able to locate to either third nerve or fourth nerve or sixth nerve, always look for isolated cranial neuropathy, which are any nerve cause, not the brainstem or cerebellum. So during neuropathy, like any ischemia is there, any trauma is there, or any localized raised ICT is there. So look for that, especially if there is only monocular palsy, only some symptomatology of one nerve is involved. So if there is version movement or pursuit, if he is not able to smoothly follow the movement, so pursuits are affected, or if he is not able to suddenly shift, saccades are problem, then always look at the brainstem or cerebellar problem. So because conjugate movements are all coordinated by brainstem and cerebellum. So always, then you all go for imaging. One of the main mistakes we do in the case of evaluation of diplopia, any ophthalmoplegia, is you only get CT brain or MRI brain. So that is not enough in the case of evaluation. Always get CT brain with brain skull with orbital imaging. So then only, because most common cause of the 10 to 15% of causes only will have some TAR, CVR problem or some brainstem related problem. 95%, like most of the 50% of cases will have some pathology in the nerve course, like there is some tumor compressing the like the posterior communicating artery aneurysm can compress the oculomotor nerve, that can cause oculomotor nerve paralysis. So that won't be detected in the routine CT brain imaging. You need to get MRI angiogram or CT angiogram. And also some like let's say some brain CP angle tumor might compress the nerves, can cause cranial nerve paralysis. So they can also have they can also might not be detected in the routine CT imaging and all. Sometimes orbital, at orbit level, some orbital tumor might be there, some thyroid eye disease might be there. They might not be picked up on the routine CT brain imaging. So always, when possible, always get a CT brain. If you are not finding, especially if there is no suspicion of focal deficits are not there, some hemiparesis is not there, some cerebellar symptoms are not there. So you are only finding some difficulty, and especially in your examination, binocular vision testing, like circuits are normal, pursuits are normal, and all are normal, and there is no nystagmus and all, always try to get a whole imaging of CT brain with orbital imaging and skull imaging, so that you'll get a brain, so you'll get a whole idea what is the problem. So then especially if there is a trauma, always advise CT. If there is non-traumatic, always advise MRI. Go for MRI. Non-traumatic MRI, traumatic CT is what we advise in the case of imaging. So next, case 2. A 34-year-old male experienced a transient visual distortion characterized by seeing double images while watching a tennis match. Only while he is watching a tennis match, he developed a sudden diplopia. Here is a breakdown of key points and significance. So a patient developed a double vision specifically when watching his daughter serve the ball, describing it as seeing two tennis balls for a second. This suggests the temporary issue with eye coordination. Like he's only observing it when she is serving, like not routinely. He's not having routine diplopia is not there. Only when he's serving the ball, he's having two tennis balls. So she doesn't have any symptoms of eye pain or drooping of eyelids, or any on routine double vision is also not there. So based on this symptomatology, only when he's serving the tennis ball, he's having diplopia. So what might be the cause? Upon examination, saccade testing, where you put the two fingers and the extreme ends and nose point, sudden shifting, rapid eye movements you check. Concealed a condition called right intranuclear ophthalmoplegia. How do you test it? So generally, intranuclear ophthalmoplegia is due to the impaired adduction. So generally, what is the problem in intranuclear ophthalmoplegia is, so your sixth abducent nerve communicate with the third nerve, with the medial longitudinal fasciculus, so that when you are looking at the right, so when the right abducent nerve is working, left medial rectus also should work. So this is coordinated by MLF. So this MLF is affected. So if you are looking at the right, left eye won't converge. So it won't come to the middle. So this will be affected. Then we'll have abduction nystagmus and adduction fallacy of the left nerve and abduction nystagmus of the right nerve. So here the same thing is happening in this patient. So when you routinely check in this patient, the convergence will be normal. Like when you are asking to look at before you like convergence, when you ask the both medial rectus to converge, it will be normal. Medial rectus is functioning normally only. But when you are having a conjugate movement, when you are asking him to look at the left or something, when left lateral rectus is moving, this left lateral rectus is not able to stimulate because of the damage of the medial longitudinal fasciculus. It was not able to cause conjugate movement of the medial rectus of the right eye. So this is a case of intranuclear ophthalmoplegia. So this is a case of INI. I know where there will be abduction of the in like the left eye in the case of abducting eye, and the fallacy of the right eye, which is the medial rectus. So the rest of the conjugate movement, this can be differentiated. How can you tell this is not a third row fallacy? You ask for conjugate movement, like conjugate movement. You ask him to move the medial rectus. When you ask, you adduct the normal eye. You ask normally to adduct the right medial rectus, it will adduct normally only. You ask him to converge, like ask him to look at a center point, look at your nose or something. He will be able to converge normally only. Only he is able to look at when you are looking at the left or something. When your opposite abduction is working, then right medial rectus won't work. So that will help you differentiate between the INO and the third nerve fallacy. So this is a case of intranuclear ophthalmoplegia. So the intranuclear ophthalmoplegia is generally seen in the case of, especially in younger patients, like less than 50 or something. Most common cause is multiple sclerosis. So any demyelinating disease is the most common cause. Generally, we see the multiple sclerosis cause. If it is more than 50 years, then brainstem bleed or some CV or something is the cause. But less than 50 years, generally, it is a demyelinating disorder. So this is the second case. You have seen a case of INO where you have seen only diplopia when you are abducting, like there is a conjugate movement. On routine convergence, it is not there. So that is very subtle. That is how you should ask. So this patient observed only diplopia when the patient is serving the ball. Routine diplopia is not there, because when routinely he is serving the ball, he has to completely look at the extreme left gaze or something, then he is having the diplopia. So that is why then the medial rectus or the right medial rectus is not working. That is a suggestive of INO. So on examination you can clearly tell differentiate between third nerve and INO by doing the convergence. In convergence, third nerve fallacy is not there because convergence will be normal. So a 64-year-old male experiencing binocular horizontal diplopia. So there is horizontal diplopia, and the patient reported binocular horizontal diplopia that started 2 weeks prior. This means he sees two images side by side while when using the both eyes. So the diplopia is particularly bothersome when looking at the distant objects. When he is looking at the distant objects, he is having diplopia more. So as when driving, and is more pronounced when he looks to the left. So when he is looking at the left also, it is mooring. So by this you can tell. So what is the importance of when you're looking at distant objects or nearby objects, diplopia is more prominent. So when you're looking at the distant object, you use by lateral recti more because you have to diverge more. When you're looking at the nearer object, you use the medial recti more because you have to converge more. So if the diplopia is more prominent when you're looking at the near objects, you should always suspect the medial rectus palsy. When you're looking at the distant objects, you are having diplopia, you should always suspect lateral rectus palsy. So in this patient, mostly lateral rectus is a possibility, and it is increased on he looks at left. When you're looking at the left gaze, it is more suggestive of left lateral rectus palsy. So the patient also has a history of hypertension, diabetes, and dyslipidemia. So there is also a certain risk factor. This medical history is there. On examination, left eye does not fully left eye does not fully abduct, indicating a problem of lateral rectus palsy, which is innervated by abducent now. So classically, as we mentioned, horizontal case palsy, distant. So distant is more divergence, more lateral recti. If convergence is a problem, more medial rectus palsy will be there. So and also left gaze it is worsened, morely left lateral rectus palsy. So on examination also left lateral rectus palsy is there. So alternate cover test also showed esotropia, that is not more of ophthalmological rather than us. So the findings are consistent with, so this is the microvascular cranial nerve sixth palsy. This is why it is important. So if you look at the sixth nerve palsy, mostly you will go and do imaging and all, where you expect some brainstem lesion and all. No, you won't find. Most of the isolated cranial nerve palsy are mostly peripheral nerve related possibly. So this might be a case of microvascular cranial nerve sixth palsy due to the patient underlying vascular risk factors. Because of the diabetes and hyperlipidemia, vasonervosum might be damaged. That is causing the isolated sixth nerve palsy. Sometimes raised ICT is also a possibility. Always look at CT if there is CSF, and get a CT imaging done if you look for any tumor or raised ICT features, or always get a fundoscopy examination also to look for any papilledema for raised ICT. That should be done. But don't always think just because an isolated sixth nerve palsy is there, isolated third nerve palsy is there, that is always a central cause, a brainstem problem or midbrain problem. Generally, brainstem and midbrain problem will have other symptoms also. Sometimes midbrain problem will have some they will have some tremors or some ataxia will be there, some hemiplegia will be there. The isolated only third nerve palsy won't occur. They will have other features also, tremor, ataxia, hemiplegia will be there. If it is going to the brainstem, the other nerves, other nerves also should be involved. No, 7, 8, 9, 10 are also there, and also the hemiplegia, hemiparesis will be there. Like sensory loss might be there. So there are other functions of brainstem also, just not this isolated. So when there is isolated palsy, always look for the peripheral causes. So then also look for in the case of 6 now, you look for any raised ICC. So this might be a case of microvascular cranial nerve 6 palsy because of the underlying comorbidities. So what are the other possibilities in this case? So let's say isolated, there is no problem. If there are no comorbidities, always look for the orbital causes. If there is any thyroid eye disease, in thyroid eye disease they will have proptosis, eyelid congestion, conjunctal erythema, and also they will have this classically thyroid function. The other hyperthyroid symptoms might be there. Then especially in elderly people, giant cell arteritis always should be looked for. So giant cell arteritis can present with monocular vision loss, can also present with diplopia also. So giant cell arteritis is something you should always keep in mind when you are looking at the 60 or 70-year-old. They'll have classically monocular vision loss or diplopia might be the present. Always look for temporal artery tenderness. Always look for them. So next case 4. A 60-year-old male present with the complaints of left-sided hemiplegia with diplopia and tremors. This might be a case of midbrain and brainstem stroke. So this might be a case of brainstem stroke. This might be a case of brainstem stroke because of the associated symptoms. Generally, brainstem or cerebellum will have associated cerebellar or brainstem symptoms. A 50-year-old male complaining of ptosis along with diplopia which is worsened by evening. So generally 50 year old, like diurnal variations are most commonly seen in the case of neuromuscular junction problems. So this is something I told you in the case of evaluation of like localizing neurological symptoms also. I am again reiterating here. So any patient that is complaining of ptosis or diplopia that is more in the evening than morning should always suspect any neuromuscular junction problem. That can be myasthenia gravis or Lambert-Eaton, and mostly myasthenia gravis is more common thing. You can check it by ISPAC test or hydrophonium test, and also you can do anti-acetylcholine receptor antibodies and anti-musk antibodies or anti-LRP4. Generally you can go acetylcholinesterase inhibitors and they'll improve. So what are the other symptoms that can be present in myasthenia gravis? They can have dysphagia, dyspnea might be presentation, or diplopia, ptosis might be presentation, sometimes meekness will be there. So always ask if there is any diurnal variation is there, always ask for such symptomatology. That might be a cause also. A 60-year-old female complaining of pain on eye movement associated with proptosis and redness of eyes. Always when they tell you pain on eye movement, always look for orbital causes. Pain on eye movement is classically seen in the case of orbital causes. That can be thyroid eye disease, that can be orbital lymphoma or orbital myositis. Anything is a possibility. So here pain on eye movement associated with proptosis and redness of eyes. First thing I'll think about is thyroid eye disease. One thing thyroid eye disease you should check for goiter and always get a thyroid function test. So generally thyroid eye disease mostly commonly affect inferior rectus. So inferior rectus is the most commonly thing that is involved. Inferior rectus, superior rectus, then medial rectus. Lastly, lateral rectus is involved. So inferior rectus is the most common. Depression is the most common defect in the case of thyroid eye disease. Second possibility is orbital myositis. They will also have some what do you call it? This pain will be there, pain will be there, and also muscle involved, like the diplopia will be there, and proptosis will be there, congestion will be there. That is also called orbital myositis. Most commonly associated with IgG4 related orbital myositis. So that also present with similar complaints as thyroid eye disease. But the only thing is thyroid eye disease does not cause involve tendons. So tendons are spared in the case of thyroid ophthalmopathy, whereas in the case of orbital myositis, tendons are also involved. So what is the reason is because TSH receptor antibodies are more against the muscle tissue than tendon tissue. That is one more reason. And one more thing is orbital lymphoma, especially when there is a chronic autoimmune disease or something. Orbital lymphoma can also cause these symptoms. So pain on eye movement, redness, and also proptosis, always thyroid eye disease or orbital myositis, orbital lymphoma. But all the possibilities of diplopia. So now again I want to brief out one third cranial nerve paralysis. So third cranial nerve paralysis can be pupillary sparing or pupillary non-sparing. Most of the cases of pupillary sparing cranial third nerve paralysis are generally related to microvascular complication of some diabetes, hypertension, and dyslipidemia. So always look, if pupillary sparing is there, then look for the microvascular complications of some diabetes or something. If pupil is involved, isolated third nerve palsy is there, always look for any tumor, a posterior communicatory aneurysm that is compressing the oculomotor nerve. So any mass effect is there, that can be tumor or posterior communicatory artery aneurysm or anything. So if there are associated midbrain or brainstem features always look for the brainstem lesions also. But this is how you go. If pupillary sparing, always look for microvascular complication, which is reversible with the management of diabetes and dyslipidemia. If pupillary sparing is not there, if its pupils are also involved in the case of oculomotor nerve, always look for a mass or a tumor or a posterior communicating artery that is compressing the third nerve. If the other midbrain features are also there, always look for the brainstem lesions. And one more important thing is in the case of oculomotor nerve palsy, let's say left oculomotor nuclei is involved, oculomotor nuclei in the brainstem is involved, then they'll have all the features of left oculomotor, like left eye ophthalmoplegia, but they'll have right sided upward eye movement defect, like upper eyelid movement and upward eye movement weakened, because left oculomotor nuclei will supply the right superior nectus through right oculomotor nerve. So left eye of the oculomotor nuclei will supply the right superior rectus through the right oculomotor nerve. So and also even levator palpebrae superioris of both eyes supplied by a single central nucleus in the brainstem. So that will supply the both levator palpebrae superioris. So if that is affected, one side left side is affected and right side also will be affected. So that is why, because single nuclei is affected. So that is one more important thing. So just if left oculomotor nuclei is affected, right side superior rectus will be involved. If left oculomotor nerve is involved, that will involve the same side. But if oculomotor nuclei is involved, it will involve all the left side oculomotor muscles, and the other side is it will involve the right superior rectus muscle. So that is because left oculomotor nucleus will supply the right superior rectus to the right oculomotor nerve. So that is one more thing because of the decussation and all. So and that also LPS is supplied by central nucleus in between. So always look into this third nerve cranial palsy. And the fourth cranial nerve palsy, as I mentioned, most common cause is always one of the most common causes is trauma. If the previous history of trauma is there, abducent palsy like superior oblique nerve palsy will be there. So always look for that, and some congenital dysgenesis or congenital problems is also a possibility. In the case of sixth nerve palsy, always look for if there is any history of raised ICT or some tumor is there, or some cortical sinus venous thrombus is there, any brainstem lesion is there, that is pontomedullary junction tumor is there, always look for that cause. And also if it is not there, mostly idiopathic is the cause. So one of the most thing about it, always get a fundoscopy done and rule out any raised ICT features. So these are the various skin conditions you discuss in the case of diplopia. First thing, look for any monocular or binocular diplopia. Most common cause of monocular diplopia are ocular causes. So always go to pinhole examination. If pinhole examination is normal, neurological causes are ruled out. In the case of binocular diplopia, always ask for any comorbidities, because microvascular injury of nerves is very common. Second, ask for gaze. If there is gaze, if there is certain gaze, it is worsened. If it is gaze evoked, mostly it is a neurological or some oculomotor problem is there. And orientation, whether horizontal or vertical or torsional. So horizontal is medial recti and lateral cuttae. Vertical is superior and inferior recti. Torsional is mostly superior oblique or inferior oblique. Diagonal is involvement of both medial and inferior, medial superior and inferior recti. That is oculomotor problem. And always ask if it is persistent or intermittent. Persistent is most commonly pathological, whereas intermittent is mostly physiological or some latent squint or some eye strain. So always ask for any history of trauma is there. So always ask for all of these conditions. Always when you're examining the case, also always check in at the always at the fixation. Look at the single point. Look for any square wave jugs or nystagmus is there. Then check each eye separately for any like medial rectus palsy or lateral rectus palsy or superior rectus palsy is there in each eye. Then look for binocular vision also. This is one thing we miss. Binocular vision, check for the eye movements, like conjugate eye movements are present or not there. Any pursuits, if he is able to follow finger properly or not. Then look for saccades, like as a sudden rapid change in movement, one finger that side, one finger this side. So if there is any problem in saccades or pursuit or aversive movements or any nystagmus, is there, always look for central cause, like brainstem or cerebellum is the problem. So then you look for the any, in the case of intranuclear ophthalmoplegia, where you look for only sudden change in the only sudden conjugate movement is the problem. Normal convergence is not a problem. We discussed about it. Then always look for the any orbital causes. Any orbital causes, mostly they will present pain in the eye, proptosis in the case of thyroid ophthalmopathy, orbital myositis, and orbital lymphoma. In the case of myasthenia gravis, they'll have fatigability and all, and also other dysphagia, dyspnea will be there. So these are all the various possibilities. Always when the patient present with diplopia, only 10 to 15% of cases will have some TIA, CVR, some central cause. So other will have isolated, especially isolated cranial nerve paralysis. Most of them are related to isolated cranial nerve that can during the course from the after infranuclear, that is after brainstem to the eye, something will be a problem. That can be tumor, that can be microvascular event, that some can be posterior communicating artery aneurysm, or some trauma might be a problem that can be handled. So always get an imaging when you're getting imaging done. So we are not suspecting any focal deficits or tremor. Always get a CT brain along with the orbital imaging, along with the skull imaging, or MRI. If there is no trauma, MRI brain with orbital imaging with like MRI angio also, if they are suspecting aneurysm or something. So this is one of the important things I want to highlight. And third, now I mentioned, if pupillary sparing, diabetes or microvascular, pupillary involved, tumor or a posterior communicating, if brainstem symptoms are there, always look for the central cause. Fourth most common cause is trauma. Sixth most common is idiopathic or ICT is the possibility. So always don't jump into the conclusion that these are all CVR, some TIA, or always that it needs to be a central cause. The most peripheral causes are also, like you should look at supranuclear level, frontal level, where there is any frontal symptoms are there, then nuclear level, brainstem symptoms like hemiplegia, tremors, ataxia, other brainstem symptoms are there, a sensorium problem, infranuclear level, any comorbidities, trauma is there, or any tumor symptoms are there, or any posterior communicating artery aneurysm is there. Then orbital level, especially when pain, proptosis, or like movement, pain with movement of eyes and all, and also congestive symptoms are there. Always thyroid ophthalmopathy or orbital lymphoma. Then neuromuscular junction, fatigability will be there. Or then monocular diplopia, look at the corneal problem, lens problems, cataracts also in the case of monocular, not in the binocular, mostly in the binocular. So these are all how you work in the case of diplopia. Thank you.